Yes, Assalamu alaikum. I'm Dr. Ather Iqbal from Sheikh Hospital, Lahore. And everyone can hear, can see my presentation?
Yes, yes, you can start. We
Right,
can
sir.
see.
Right, so time is brain for us as well. Wonderful talk by Dr. Fatima. Uh, Half of the work is done. It's much easier now. So what we are going to be focusing on here is how to familiarize ourselves with the basics, and the basics are partly already discussed. And NIH is brilliantly done, and the few CT issues are done. Uh, my focus is going to stick on, especially considering 20 minutes, I would focus on the exclusion criteria, and some of the exclusion criteria more than others, which are interesting, and some of the pitfalls while you're managing the intravenous thrombolysis. Of course, just touching the global phenomena that overall it's a disappointing number how many patients are being thrombolized, and we have our own set of exclusive problems like unavailability and cost. I think throughout the conference this will be talked about in great detail, and we cannot emphasize more on this area. But one thing is that yes, stringent and old conventional, the earlier on the exclusion criteria were also kind of hindrance, but now the latest by the American Heart Association 2018 has cleared some few of the concept, and then raised basically few of the concerns and discussion. So one needs to rationalize each and every element of the exclusion criteria on case basis. Talking from the inclusion and the screening approach, yes, you need to have a patient in front of you with a clinical sign and symptom which is suggestive of a stroke. Now, I would slightly elaborate on that later, but in addition to that, yes, you need to have a GCS above 8, because anything less than 8 at the onset of symptom would mean that we are talking about maybe the stroke mimics. For a stroke to give you that kind of low GC, it has to be a basilar infarct either, and that's a little rare. Of course, the time of onset has to be crisp and very well defined. Less than 4 hours, ideally 4.5 is the whole window. Lesser the better. The earlier the better. Great if it's less than 3 hours. Age limit used to be 18, but then case to case basis, the operator can actually consider 16 as well. Uh, yes, the whole point of thrombolizing or not thrombolizing anyone is to restore the functional independence. Remind you, so if somebody is already debilitated or bed form bound for other reasons, mentally demented, then this is also a discussion that has to be brought onto the table with the family, that what are we trying to achieve. Yes, of course, at the time where you are considering thrombolysis, the patient has to be having an ongoing deficit. Sometimes it's a resolution of deficit, so one has to be cautious on that front, because sometimes the shrinking deficit shrinks to such an extent that it's a non-disabling stroke anymore. One tool that I've found very useful in my days, and especially elaborating on the first point here, the does the patient has a clinical sign and symptoms suggestive of stroke? Just elaborating onto this, one stroke score I find very interesting, especially for the first line of defense, the ER gentleman. The scale has actually a scoring system starting from -2 to +4. The more you go positive, the more chances that the patient in front of you is a stroke patient. It's a basic question and answer, which is a kind of a rule of thumb for the non-neurologist, especially. You just ask whether the patient has lost consciousness at the onset. If the answer is yes, then you are going to score it as -1. This will take you away from the possibilities of a stroke in front of you. Again, the question whether the patient had a seizure. Of course, we are familiar with the post-stroke seizure phenomena. It's a very well established, but at the onset of symptoms, very rarely it strokes presents with seizures. But if somebody says yes, then of course one minus again, it takes you away from having a stroke. The rest of these are all signs, which are all the cardinal signs of stroke: ipsilateral weakness, ipsilateral leg weakness, speech disturbance, visual field. These are hardcore signs, and any yes would be in +1. And if you are moving towards beyond 0, anything would be more likely. So you can press the stroke code button and initiate the stroke call. Of course, one cannot stress more on this aspect. Fast Still not a household phenomena. We need to bring it as a household phenomena so that even household as well as for the emergency ambulance crew as well as for the ER team. So this has to be always kept in mind, discussed earlier as well. NIH has been really spoken about. So coming to the most valued part of my presentation is the exclusion criteria. They say first, the most absolute exclusion criteria is obviously acute ICH, no questions on that. But what about the history of ICH? The initial absolute, it was part of the absolute criteria in 2013. But now you see, it all depends. When did it actually happen? What was the site? What was behind that bleed in the past? Was it an AVM that bled? Was it an aneurysm? How much investigated? At how much was it investigated at that time? So all of these questions needs to be put on table. A lacunar infarct, a lacunar bleed, or a small bleed secondary to a trauma 5 years ago would mean something different from an aneurysmal bleed. So that has to be discussed. Now that we have better imaging modalities, susceptibility weighted images, especially, we use this for our cold cases of identifying whether it's a cerebral case of cerebral microbleeds or not. So the discussion nowadays is that whether we can, now that you know in such a patient that there are microbleeds, are you going to thrombolize or not? So I'll talk about that later. But for now, microbleeds in a previously known patient who's known to have microbleed, it's not a contraindication for TPA. Of course, the number of microbleeds matters a lot. And uh, yeah, so uncontrolled hypertension. You're not going to thrombolize anyone above 185, 110. The studies are against the outcome. Yes, it's not a big deal to bring the blood pressure down most of the situations. We will be talking about later. Hypertension does have a poor outcome while you're thrombolizing and post thrombolysis next 24 hours. Recent head traumas and a stroke in the previous 3 months. Is that an exclusion criteria? So recent head trauma needs to be explained further in the last 3 months. Yes, the data is very little on that. But stroke in the last 3 months, you see, stroke in the last 3 months, again, depends a lot. What sort of a stroke was it, which happened in the last 3 months? There are situations where, of course, case reports where they've thrombolized twice within the few hours because the first thrombolysis has been successful and the patient re-occluded, and a second arterial occlusion, and in between MRI diffusion scan being negative, assuming that the first is recanalized completely. So there's a case report, but of course these situations are rare, and one has to know exactly when the first stroke happened. Was it a lacunar infarct, or was it a large territorial infarct, large artery? Of course, the consequences of of thrombolizing such a patient would be different in both the situations. What about the platelet count? So it's not a rule to actually know platelets unless you have a reason to suspect that somebody would be having thrombocytopenia. A patient of chronic liver disease and chronic renal failure would be reasonable to get a platelet count before you launch TPA. But anything less than 100,000 is contraindicated for sure. Recent guidelines of, okay, so with the INR of more than 1.7, of course, not for thrombolysis, but it is an absolute contraindication. But the argument is, well, what about patients who are on subtherapeutic INR? So what the tools we have in hand is, if the INR is less than 1.7, and the time of onset or the window is still less than 3 hours, so the American Heart does allow it to accept thrombolysis, but the Europeans are totally against anyone who's on INR, on warfarin, irrespective of INR. These days we have these coag meters as well, which is very handy. Not very specific, but handy in checking the INR. Anyway, it's a 20-minute drill, so you can agree, if you can get agreement with the lab within 20 minutes, they can certainly get the platelets as well as the INR. And 20 minutes, of course, is taken. So many things to do before we thrombolize. Low molecular weight heparin. It is the most, yes, anything, somebody has received therapeutic dose of low molecular weight heparin, so not to be thrombolized within 48 hours. Talking about the DOACs these days, the novel oral anticoagulants, the Vigatran, which is the only one who has having any indicator whether it is functionally active or not, is the thrombin time, very rarely done in Pakistan. But the rest of the DOACs, they don't. It has a reversal agent as well, but unavailability is an issue. The rest of the DOACs that we are much more familiar with is apixaban and rivaroxaban. The end point is 48 hours. So 48 hours in between, if somebody had it, then we unfortunately cannot thrombolyze such patients, even before the elimination half-life. We talked about hyperglycemia and hypoglycemia. So in the revised guidelines, they've exclusion criteria. They only include hypoglycemia as part of the exclusion criteria. Why? Is because we know hypoglycemia is a mimic. We also know that both these entities, hyper or hyper, they have they would worse brain ischemia as well. And even if you thrombolize, they would have higher chances of reperfusion and lesser chances of recanalization. But now we know that if somebody is hypoglycemia, of course, it's not a big task uh, to improve the glycemic control and give dextrose. The question is, what are you going to do if you've brought up the hypoglycemia, blood sugar levels, and the patient clinical deficit is still not improving? The consensus so far is that we should not, since time is brain, we should not be waiting for the clinical neurological deficit to resolve completely after fixing the hypoglycemia. If the patient persists with weakness or partly has resolved, most of the neurologists are going to go ahead with. Dr. Fatma has elaborated on this part nicely, and these are the early ischemic changes on the brain, CT. So the frank hypodensity is what you need to look for. It's a new term, a stroke-based term developed, and I think she has done a great job, so I should not be focusing on this part and moving forward. Again, in the same context, the mismatch between flare and diffusion. In this scenario, you can see this is the flare image where you got this is a diffusion restriction seen, and the flare is fine. So there's a mismatch, and there's a possibility that the stroke has happened within 3 hours, and one can move ahead with thrombolysis. What about age and dementia? Is age a risk factor for not thrombolizing? So age is not a risk factor. Age is not a contraindication. And what we know through experience is that patients in their 80s and 90s, they have poor outcome, in their less chances of actually achieving their favorable outcomes than patients less than 80. And the reason is because of the disability, debility overall, the frailty, the lack of engagement if elderly with the rehab team. It's not that they would bleed more. They're not going to bleed more. They would because of the age and the frailty, they have poor outcome. Dementia is not a contraindication, but has to be brought onto the table. Okay, what functional status actually are you going to achieve, and what stage of dementia is somebody on, and what is the deficit which, if the stroke is left on its own, how is that going to change his life and the family's quality of life? Talking about mildly improving deficit or improving deficit mild strokes. So you see somebody who's got improving deficit from the first stroke. Yes, one has to be cautious while thrombolizing and wait, but sometimes it happens that the shrinking deficit happens earlier on, and then the patient is at a stage remains at a stage where there is still a moderate disability. So it's a judgment call that if you're still left with a moderate disability, although it has resolved from the initial disability, thrombolysis is reasonable. Talking about major strokes and large and high scoring NIH, you see, it is always tricky and risky to thrombolize patients beyond 25 NIH, and the trials done have not included this patient group within, but it is overall advisable to go ahead if it is within the early time frame, which is 3 hours. So there's a class 2B evidence in support of that, and most of the neurologists would go ahead with NIH above 21 if the time window is less than 3 hours. GI bleeding, for remote bleeding, it's reasonable and relatively safe, but in recent times, GI bleeding, which is 21 days, TPA is contraindication. Menstruation, of course, no issues with that. Seizure and onset. So how many of us would actually not thrombolize somebody having a seizure at the onset, and what it holds, this very exclusion criteria holds within itself? So you see, we know it's a Todd's palsy is a phenomena which can momentarily give you false localizing signs, but they say that in especially parts of the world where you're not paying for the TPA and thrombolizing a non-stroke, non-vascular weakness, 300 out of 2 would bleed spontaneously. So it's a far less chances of bleeding within a non-stroke patient than a stroke patient. So in overall, the survey say that 91% of stroke neurologists would go for TPA. So one can decide for themselves. There's a question in the query box that what about the acute MI and the recent MI or concomitant MI? So it is all right to go ahead with TPA in cases of concurrent MI, acute MI, uh, especially followed by percutaneous angioplasty. But the problem is with the recent MI. Recent MI within the last 3 months, more so with the ST elevation MI. Non-ST elevation MI are relatively safer. More issues with the anterior wall involvement. Inferior wall involvements are relatively safer, but the problem is within the last 3 months because the risk of myocardial wall rupture, hemorrhage within the pericarditis, and further embolization of a setting ventricle thrombus is possible. So that is a tricky. What about the extracranial cervical dissection? Yes, we go ahead with TPA. Intracranial arterial dissection, this area is little unknown, and most of them would avoid. Unruptured intracranial aneurysm, it depends on the site. If it's less than 10 millimeter, you can go ahead with it. Intracranial vascular malformation, not well known risk, but it is certainly risky, and most of the neurologists would also refrain from sitting intracranial aneurysm. What about if it's a non-compressible arterial site, especially the subclavian or jugular artery rupture in the last 7 days? It's a contraindication. And once you've decided, once you've decided on TPA, in the consenting stage is the next stage. We send all the bloods done. Both the cannulas, both the arms needs to be cannulated, and IV cannulas, because if one fails in between, you cannot puncture the patient again with half of the TPA in. The maximum dose is 90 milligram for us, 0.9 mg per kg to start with. We give 1%, 10% as a bolus, and the remaining over an infusion over the next 1 hour. This is how it looks like. It comes with a connector, and what you do is that you keep the fluid part above and the disc and the dry substrate substance below, and let it flow nicely, and it flows nicely. Try not to shake it, try to avoid bubbles. A few bubbles are natural, but then you can wait for a minute to settle before you can extract that 10% out and give a bolus. Initial monitoring is crucial. Blood sugar levels needs to be in range, ideally less than 200. Blood pressure level needs to be in range, ideally less than 185 systolic, better if less than 160. There are tools, of course. Labetalol works nicely, especially for initial on, because you can always repeat short boluses every 10 minutes, 10 to 20 milligram IV to bring it down below 180, better if 160, and you can then later start an infusion. With maximum dose, you can go up to 300. So the issues can be somebody is asthmatic, or you're going towards bradycardia, then you have to switch to other options like nitroprusside or diuretics. Generally, we avoid isocate in hypertension, in controlling blood pressure when you're targeting TPA. The reason being isocate can give you headache, and headache, is a red flag for us. Post TPA patient if complaining of headache, so that's a nightmare. Avoid nasogastric tube initially, ideally, but there's a practice to put the tube in if you can already see that the swallow is impaired, to put the urinary catheter in if you can see that the patient is disabled. But the thing is that if you do it before TPA and there is minor abrasions as through the path, you give TPA, and then everything would start bleeding, and it will create a mess and a panic. So try to avoid that for 24 hours. It doesn't really matter. What happens if there is anaphylaxis or angioedema? Always have a look if the patient is on ACE inhibitors, because angioedema, bronchospasm is a phenomenon not very unknown. You stop the infusion immediately, you give steroids, hydrocortisone can be given, but ideally adrenaline and solomedrol 125 mg can be given in serious situations. Chlorpheniramine, which is an anti-allergy, can also always be given in this situation. And sometimes swollen tongue can be because of angioedema. It could be a bleeding within the tongue. So that can be sorted with the CT head there and then. What are the red flags? Yes, acute deterioration of GCA, seizures after TPA, deterioration of GCS after TPA, new headaches, immediately get a CT head done. So that's why not isokid, because isokid would give you headache and you would never be able to figure out why is it happening. Acute hypertension and nausea, vomiting. So the blood pressure was very well controlled during and before TPA, but 2 hours, 3 hours later, somebody has got a spike of blood pressure. That's also uh, a little red flag. So you bring in, you send all the bloods, stop infusion, check the get for cross matching in platelets, and sometimes if the cryopress plates are available, that can be administered. If the platelets turns out to be low, platelet can be infused as well. Uh, I'm trying to fit in my presentation within time. So this is my institute, and we've opened the stroke unit, 4-bedded stroke unit, and we've just started thrombolizing our patients. And hopefully, once once TPA is formally available, the numbers will increase more rapidly. Thank you very much for your time.